Good morning. Can anybody hear me who's on? Oh, wait a minute. Good morning, Eileen. How are you?
Good morning, Lisa. I'm fine.
Hey, Lisa. Can you hear me?
Yeah, I can hear you, Bill. Yep.
Great. Everybody can hear me. That's great. Okay.
Can you all see my slides?
Yes.
I'm looking right at it, Lisa. Looks great.
Right.
Okay, super.
Can you hear me?
Yep, I can. Yep. Who is that said that?
Maybell.
Maybell
Sorry?
Erickson.
Yep. You see me?
Yep.
Okay.
What's strange about
Eileen. Hi, Eileen.
Yes.
I said hi.
Hi. How are you, Maybell?
Before everybody gets on, I had an interesting experience. My nursing class reunion from the University of Kansas was scheduled for the first weekend in October. It was 50 years for me. And we had a Zoom meeting. Not ideal, but it worked.
There's Mary. I know you probably had the same problem this morning with the church service, not getting frozen. And I was sorry about that because the announcement of the form would have been on there, and I'm not sure how many people will follow up because of missing that, but we are certainly happy to have the doctors, Lisa Kirkland and Bill Wagner with us this morning. It's a great privilege for us to hear what you have to say.
Well, thanks for having me and thanks for having us.
Yes, indeed.
Yeah, we've Dr. Wagner and I are co-directors at the Abbott Northwestern Hospital OB Critical Care Program, a program that began in 2018, but was years in making. So, Bill, do you want to introduce yourself a little bit?
Sure. I am a partner with Minnesota Perinatal Physicians, which is our maternal fetal medicine group within Allina Health. I'm also a member of Lisa's partnership with the Department of Abbott Northwestern Critical Care Medicine. I had a bit of a unique, if you will, training program following my residency in OBGYN at the Medical College of Virginia in Richmond, having graduated from the University of Iowa College of Medicine. I actually was born and raised in New York City, but I married an Iowan, so that's probably the best thing I did. And following my residency, I was one of the first of maternal fetal medicine individuals of interest to do a combined fellowship in both maternal fetal medicine, which is the specialty which deals with the complex medical and potential surgical problems of pregnancy, and at the same time, a combined fellowship in both medical and surgical intensive care. There were a number of us that had given that opportunity and privilege, and that was actually done back at my home birthplace at alma mater at the New York Hospital and Cornell University Medical Center, which is now New York Presbyterian, part of the Cornell Medical System, along with Columbia, if you will, College of Physicians and Surgeons. I actually stayed on the staff at the New York Hospital until they decided to convince to get my other half and our girls out of New York City and transition back to the Minneapolis area. And actually having been given the privilege at the New York Hospital to start one of the first dedicated OB critical care programs, that really was the impetus for, shall we say, and I use this term euphemistically, that Dr. Lisa Kirkland and I gave birth to this program, if you will. Both of our biases obviously directed, if you will, towards, maternal well-being. Presaging, obviously, many of the particular topics of discussion we'll talk about today was obviously to improve access, outcome, and reduce the concept of both disparity and diversity. So that's a short synopsis of me.
Very short, because you have a lot to say. So let me ask, I actually had to close out my screen sharing. What are you all seeing right now on your screens?
We're seeing every person who's come on
okay.
and have their camera on.
Okay.
We have Joel has joined us, Pat Robbie has joined us, David, who I'm not sure who David, and which Ted. David, and Ted Colescott have all joined.
Okay, excellent. So like I said, what I'm trying to figure out is when I go to screen share, then I can't seem to see who the participants in the waiting room are. So then I can't invite them in.
Yeah, can't you do it down for participants, Lisa?
Well, I clicked on that and I clicked on chat, and then
you should be able to see under participants who's in the room.
Yeah. Okay.
Waiting.
Yeah. Right. Okay. All right. So how about if I do this? Is that just screen share now? Or just the slides now?
We're not seeing it.
Not seeing it yet, Liz, but
okay.
Maybe it'll take a moment to load in.
No, I think it's because I need to do something different here with Zoom. I'm sorry, it worked great for a minute and then I fiddled with it and now it's.
Did you go to share screen?
Go to what? I'm sorry?
Go to share screen.
Well, the trouble is that I'm not seeing that at the top of my Zoom anymore.
Look at the bottom. Can you take your cursor down to the bottom?
Yeah, I know. Let me try this again.
You're right, Eileen. Mine's down at the bottom. I don't know if the main presenter is at the top or not, but you're right, Eileen. My if your little icons are down at the bottom of the Zoom meeting, where it says share screen and participants and chats and many of the other particular issues.
Right. I know that the difficulty is I'm not seeing that. Excuse me at all. Doggone it. Rats. Let's see. I know what you mean, and for some reason I see it every other time I'm on Zoom, but I'm not seeing it now.
It says on my screen, host disabled participant screen sharing.
Right.
So if that gives any hint, you need to go down and indicate everyone can see it.
There you go.
There they are, Elise.
Okay. All right. Now perfect. I got it. Okay, so let's get going. So this topic actually is kind of disturbing to talk about. And I'm going to show you one slide that's particularly shocking about rising maternal mortality. Nobody likes to think about others dying, but it's happening, and it's happening too often. So here we go. It's a problem around the world. As you can see in the Americas and in Europe, that the incidence of maternal mortality is lowest, but it's still unacceptably high. And in Africa, of course, it's as many as more than 1,000 deaths for every 100,000 live births. And that's how this metric is reported, is the number of deaths per 100,000 live births. This screen is from 2017. And pregnancy-related death can happen up to a year after delivery. It's broken out into about a thirds, about 31% during pregnancy, 33% 1 week to 1 year after delivery, but 36% and 36% during delivery and up to 1 week after. So pregnancy is kind of a high risk condition. the postpartum period that Bill and I work in the most is up to 6 weeks after delivery. But we do keep in mind that patients 6 months after delivery can come in with problems as well that can lead to death. This is the most disturbing slide I think I have. So this is maternal mortality rate per 100,000 live births, 1990 to 2017. The United States is the green line. I find that incredibly disturbing. The blue line is the average of comparable developed countries. And you can see their rate is falling. Whereas in 2017, the United States rate was 17.4 deaths per 100,000 live births. And in comparable countries, it's well above 8 deaths. So I just find that amazing and very, very disturbing. So why can't I move on? There we go. And then in 27 to 2018, things aren't any better. It's still, well, the previous slide maybe wasn't 17.4, but for 27 to 2018, we're up to 17.4 deaths, whereas other developed countries are, again, much lower. So it's just really awesome, hard to understand. The populations, when we break it out by population, there are considerable racial and ethnic disparities in mortality. Between 2011 and 2016, the mortality ratios were for Black non-Hispanic women, 42.4 deaths per 100,000 live births. For American Indian and Alaskan Native non-Hispanic women, it's 30.4. For Asian or Pacific Islanders, 14.1. And for white non-Hispanic women, it's 13. And for Hispanic women, it's 11.3. That's through 2016.
And I think that and you can go back one, back to the previous one, Lise. I will highlight this a little bit, and it will, I'm sure, be a major topic of discussion. But I think, you know, what it clearly brings to light is that over the last 30 years, despite the advances we've seen in both care and technology, we are exponentially, if you will, exceeding the concept of who gets what care and what kind. And I think Lisa and I, and obviously this will be a major topic of the discussion as to potentially, and certainly given the limitations we now have with the other pandemic we're dealing with, which has put, at least unfortunately, some of the emphasis on this on the back burner. Go ahead, Lisa.
Mm-hmm. Yep. And we could also talk about COVID in pregnant women. I don't have that in these slides, but that certainly can be something we can talk about as well. In 2018, the statistics really aren't much better. For non-Hispanic Black women, it's fallen from 42.4 to 37.1. In white women, it's actually gone up from 13 to 14.7. And then in Hispanic women, it's roughly the same, 11.3 to 11.8. So, you know, we're not getting better as the years go by, we're getting worse. Why such disparities? Both in the United States rate, but also and also among the different races. Oops. Severe comorbidities. Comorbidities means, well, in this slide anyway, it means other medical problems, diabetes, hypertension, chronic diseases, as well as acute things that may occur during a pregnancy. Disparate provision of access to care and provision of the care, even if someone has access to it. We've been finding that there are definitely racial differences in the care that Black women get as opposed to white, even if they have access to care. The racial and ethnic disparities, maternal age at time of pregnancy is significant. The mortality rate of women over 40 is, correct me if I'm wrong, Bill, but I think it's 8 times that of women under 40.
Yep, somewhere between 7 and 9, with an average of about 8 times. You're right, Lisa. Correct.
Yeah.
Data.
Social factors, as we all know, income, housing, and education are important. And I added this one into this slide. So survival to childbearing age of those who would not have survived previously. Mostly what I think about those are congenital heart disease
Yes.
patients who have managed to survive when they didn't before, but now they undergo pregnancy, which is a tremendous stress to their system.
And just as an aside for this last bullet point, as my other hat that I wear as the co-director of our cardio-obstetric program, which manages the potential complications of those with known congenital heart disease and those who have acquired heart disease. As it comes to congenital heart disease since 1985, in fact, we've had an almost total reversal. We now have more adults with congenital heart disease than we have children with congenital heart disease. So obviously, the advances in surgical correction as well as palliative surgery has given individuals an opportunity to have children safely, obviously with our guidance, that were unfortunately faced with very difficult decisions in early pregnancies previously about what would be in the best interest of the health of the mother. So it is a major reversal, as you will see, in terms of looking at the potential for mortality.
These are the causes of death between 2011 and 2016. Bill, would you want to elaborate on some of these? Like people may want to know what other cardiovascular conditions or non-cardiovascular conditions might be.
Sure. Again, as you will see, the most common, unfortunately now, cause of death, non-obstetric, that is in origin, that is not a complication per se of the pregnancy, is cardiovascular disease and heart disease. And again, this particular issue can occur from the completion of the pregnancy up until 1 year. Certainly, when we talk about other particular conditions, we've almost essentially reversed the concept. The 3 highest likelihood of morbidity, that is significant illness or perinatal death, of which we describe as maternal mortality, have essentially completely changed. Previously, the number 1 cause was hemorrhage at some point in time during the pregnancy for a reason. The second was the development, because pregnancy is a state, if you will, that increases the potential for moms to form blood clots during their pregnancy or within a short period of time afterwards. And those, if you will, that were a part of the blood pressure disorders, that is either those if individuals who already had blood pressure problems that they brought into pregnancy, or those that developed blood pressure problems that were unique to pregnancy. And many of you may have heard of the old terms called toxemia or these kinds of things, which relate to, if you will, the medical condition called preeclampsia. And in the setting where actually seizure activity occurs, that is what we call eclampsia. In fact, those 3 particular conditions, all the way through, if you will, my training, if you will, Lisa and I are actually from the same institution at the Medical College of Virginia. As we learned through our particular time period, those were the 3 major causes of death and where the emphasis was. We really did not see issues related to cardiovascular disease really until the last 15 to 20 years. And this is where this has been a complete reversal, where in fact, the number 1 leading cause of mortality in pregnancy is complications of cardiovascular disease and heart disease. Who would have ever thought that individuals would in fact have, let's say, coronary artery disease or actually have a heart attack during pregnancy? Whom would have ever thought that people otherwise healthy and in good condition would develop issues with how their heart actually functions? In terms of looking at, you'll see the term cardiomyopathy there, which just means, cardio meaning heart, myo meaning muscle, and pathy, if you will, Latin, if you will, for illness, where the heart muscle, in fact, doesn't work as well as we would like for a number, if you will, of causes. But you can clearly see, and this is where the emphasis, and we can talk about this, I think, at great length. This is where the concept of those individuals who actually develop blood pressure issues in pregnancy are at risk for lifelong cardiovascular disease. And one statistic that most people are really unaware of: more women die of heart disease than breast cancer every year for every age group now. So this is not if you will, small issue. It's a major issue across all disciplines in healthcare, but in pregnancy, it is a major issue.
Yep. And this sort of moves into that a bit. Severe maternal morbidities, which in this case, I'm using morbidities as a term of complications not causing death. These are morbidities that occurred during pregnancy, during delivery, or after. And these morbidities that have increased from 1993 to 2014 are the use of blood transfusions, acute renal failure, adult respiratory distress syndrome, where the lungs fill up with fluid, cardiac arrest, shock, acute myocardial infarction, as Bill was talking about, or an aneurysm, the need for long-term ventilation, so ventilation or needing a tracheostomy. Sepsis has gone up, despite all of our efforts to bring it down, and the need for hysterectomy has gone up as well. Unchanged or decreased are these other medical conditions with DIC, which is a clotting problem, blood clots or air going to the lungs or the brain or the heart, amniotic fluid embolism, where the amniotic fluid actually gets into the maternal bloodstream and can cause devastating cardiovascular collapse, acute congestive heart failure, puerperal, if that's how you pronounce it, cerebrovascular disorders, possibly relating to hypertension like strokes or other or subarachnoid hemorrhages or something like that. Heart failure, cardiac arrest, again, eclampsia and severe anesthesia complications, those have stayed the same or gone down. But this list on the left is pretty disturbing, and this is what the area that Bill and I work in as for the critically ill patient. Bill, any other comments on that?
No, I think the slide again is delineates what our major emphasis is. One of the things again that we do talk about, although we you see on the right hand side, we have seen either unchanged or decreased potential issues related to anesthetic complications. In fact, some of that data, this is a little old data now, this is up to 2014, but given, if you will, the number of individuals that we're now dealing with fairly high body mass index, if you will, and that's based upon mom's height and weight, if you will. It is how the World Health Organization defines obesity. There are a number of different categories that define obesity, but certainly that population has grown exponentially for a variety of reasons, not just in pregnancy, but in all disciplines, where obviously one of the reasons that mortality for both men and women obviously have increased significantly is an issue related to obesity. That has had a tremendous impact, if you will, on the risk of pregnancy, and a tremendous impact, if you will, on the risk, if you will, for anesthesia potential complications as they may relate to pregnancy. So this data is pretty consistent, but I would suggest probably as we now begin to look into, shall we say, 2020 and beyond, the potential issues related to anesthetic risk and complications, and the potential for lifelong issues with failed intubation and these things is likely to increase. That would be the only comment I would make on this. All of these are really quite similar. The only thing I would suggest probably that might necessarily be slightly different, again, is the concept of blood transfusions. Most of that has really been related recently to the issue related to moms who have some degree of placental abnormality, where in fact they have a placenta which, if you will, is more adherent or invades into the muscle of the uterus based upon potentially the number of previous cesarean deliveries. You all in the lay public may have heard the comment of accreta, if you will, a syndrome, and accreta is just simply Latin, if you will, for attached or into, and most of the issues related to increase in blood transfusion is an issue related to that particular, if you will, obstetric complication of pregnancy.
Yeah. Bill, is there a cutoff above which, a cutoff BMI above which mortality really increases?
Yes. If you look at height and weight, which is how the body mass index, if you will, is calculated, at or above 50, if you will, with that particular threshold cutoff, the increase in potential morbidity and mortality actually increases somewhere between 7 and 10 times, again, for a variety of reasons. Many of those people, again, as I've alluded to, are at great risk of anesthetic issues. They are at great risk of an increased likelihood of having to deliver from above, as I call cesarean section, or as opposed to below. A body mass index of 50 or above, the likelihood that your pregnancy will be concluded by cesarean section is 80%. So clearly, that's a significant risk for a number of different issues: infection, anesthetic complications, bleeding issues, post-delivery complications, blood clots, thromboembolic disease. So in fact, other than heart disease, if we were to actually look at this more critically, one of the major contributors, again, not only to heart disease, that is acquired heart disease, but pregnancy complications, is the alarming and continued trend of issues related to obesity in the United States. In fact, we are one of the few developed countries where, in fact, obesity or poor nutrition leads to obesity. Most of the time, poor nutrition usually leads to inanition and relatively, if you will, poor weight gain, shall we say. We're one of the few people where, in fact, in the world where poor nutrition has clearly led to obesity, which would be a whole other topic in itself. But that's a major contributor to many of these particular maladies, which we clearly are going to need to address as we move forward for the next 10 years.
Yeah. Yeah. And just for reference, the normal BMI is 18.5 to 25. Had to consult my specialist here sitting at my table. So a BMI of 50 is very, very high. How to prevent these deaths? 60% of maternal deaths are preventable. I mean, that's an incredible statistic in my mind. 60% are preventable. And the way we should go about preventing them are sort of common sense in a way, but we need to do a better job. During pregnancy, improve access to and quality of prenatal care, including managing the chronic conditions and educating patients about warning signs. At the time of delivery, standardize patient care, including delivering high-risk women at hospitals with a specialized provider and equipment. One of the keys there is that providers need to recognize that their patient is at high risk, and so we have to educate the OB providers as well. And then postpartum, providing high-quality care for mothers up to 1 year after birth, which includes communicating with patients about warning signs and connecting to prompt follow-up care. Bill, any thoughts on that?
Yeah, to me, the highlight of this is exactly as Lisa has suggested. William Osler, who's well known to many of us in the medical field, is kind of the father, if you will, of the ability to obtain a detailed history proceeding, if you will, to a physical exam, which is really the key, if you will, shall we say, to diagnosis and management. But always reminded people, you know, if you have no idea what you're looking for, you'll never find it. And in fact, he always was a strong proponent of, in fact, the patient will tell you 90% of the time what's wrong with he or she if you give them an opportunity and prompt them, if you will. I think what this really alludes to is people, all practitioners really need to understand what are the potential risk factors for what people may bring into their pregnancy. What are the potential risk factors that can occur? And this may be, if you will, clinical issues. It may be resource issues. It may be access issues. I think the key here is to identify very early those individuals who are at risk for a problem, and then, if you will, tailor the care that that individual or individuals need to the appropriate, if you will, either individuals or centers that can manage those that are at risk. You'll clearly see as we highlight a little bit of our program, when Lisa and I started, one of the things we looked at each other and said, what do we really want to try and do with our critical care program? And we both clearly had the same understanding: to keep the least number of people out of harm's way as we can. And how we do that is, if you will, by looking for those at risk, looking at early warning signs, making appropriate, if you will, adjustments to their care to keep them out of our unit, recognizing that, yes, our level of expertise and our resource will provide those necessarily that will require that level of care. But the real goal, if you will, I think, of prenatal care, as well as it is in any discipline, identify those individuals at risk and then highlight what can you do, what is in your toolbox really, you know, to keep these individuals out of harm's way.
Absolutely. Okay. And here we go into our program, just to give you an idea of what we're trying to do in our little area to try to reduce maternal mortality.
Takes a little bit of the time for the cubes to roll around there. That's okay.
Yes, it does. Yeah. So Abbott has been identified as a quaternary hospital, which means a referral of the referral hospitals in high-risk obstetric patient deliveries. The program involves care of pregnant patients through, my screen actually cuts off here, but I think it says through 6 weeks postpartum, yes, that are deemed high risk or critically ill. It is known that treatment in a specialized OB ICU gives lower morbidity and mortality rates than in a regular ICU. In our program, in our OB ICU, and we'll go into this a bit more, but is collaboration by a specialized team, which includes maternal fetal medicine, which is Dr. Wagner's specialty, critical care OB specialists, which are critical care doctors with training in OB critical care like me, neonatal physicians, pediatric surgical teams. We have everything at Abbott. So that's where we thought it was a good place to do this program. And this is a unique OB critical care program using very close teamwork among OB and ICU nurses, as well as the medical and surgical subspecialists. So I'm gonna show you a picture, I believe, next. Yep. And the only thing missing in this picture is Dr. Wagner down here at the foot of the bed. But right. This is a picture from a training film that we made about cardiac arrest in mothers, and it illustrates the teamwork that's there. There at the head of the bed, there's an intensivist who will remain nameless. There's a respiratory therapist to the right. There are 1, 2, 3 ICU nurses around the patient, and then over on the left, there's an OB nurse who's looking at a fetal tracing. Helping to monitor the fetus as well, and the OB nurse is right there to advise the OB ICU nurses the ICU nurses, and to call in the other OB specialists as needed. Bill, do you want to talk more about the collaboration and the multidisciplinary rounds and those kind of things?
Yeah, the important piece of any program necessarily probably is much broader than the expertise of the providers that seem to usually get all the glory. But in fact, the most important part of any program discipline is all those, if you will, who are dedicated and committed, if you will, not only to the program's workability, but to its well-being. And we really, when we began this program, one of our really key factors, and unfortunately we don't have the slide, but we have a nice slide where in fact it's a little bit of a spoke and hub kind of system where in fact the patient is within the center of the balloon. Yep, there it is. And in fact, you can see that each of the individuals who are part of our spoke and hub system is really what makes this program not only work, but in fact give us the outcomes that we are so proud of, not because we're interested in how we do. Again, we're mostly interested in any patient that arrives, of which we are given the privilege to take care of within our critical care OB program. Obviously, we want to do, all of us want to do what is in the best interest of that patient, whether she is or she isn't still pregnant. Many times you have to remember that some of these patients are actually transferred for this level of care, and they still have a passenger on the inside, as I euphemistically call it, where in fact we always have potentially more than one individual to make decisions with. But I think you can see, despite the fact that the intensivist, if you will, and let's say our medical specialist and maternal fetal medicines are a bit at the top here, as you see the diagram, actually what makes this program the most important and why our outcomes are as excellent as they are of each of the individuals surrounding this. And again, the family, again, right at the center of this, maintaining, if you will, their, if you will, input and their ability to make decisions for the patient and or patients. Spiritual care, again, which is a huge part of this particular issue, particularly in the setting of some potential pregnancy loss. But I think each of these particular individuals necessarily of not only our critical care patients, but each of our patients that require critical care oversight actually have each of these particular members, as the discipline directs, at multidisciplinary rounds every day, which is a walk around, and every patient, along with their families, are an intimate, if you will, part of not only the clinical decisions, but the social, if you will, and well-being of the patient. And again, highlighting our program, without further ado, I will tell you that so far, God willing, as we would say, we have not had a patient that required our oversight that did not survive, if you will. So our maternal death rate from our OB critical care program is 0. And obviously, that's not for us. That's for the patients, if you will, who come into our unit and then survive and actually go home.
The way, and what makes ours particularly unique is that we had joint training sessions with the OB nurses and the ICU nurses together on how to care for a critically ill OB patient. Because just as providers sometimes don't cross silos, nurses don't necessarily cross silos either. So ICU nurses didn't know the special things that an OB patient may need, and OB nurses may not know or didn't know the special things that ICU nurses need. So training them together was a key program. And then when there is a pregnant patient in the ICU, there is an OB nurse who is assigned to come over and stay with that patient and monitor the patient and the fetus right there in the room. And they interact with the ICU nurse and communicate together to the intensivist and the the perinatologist or maternal fetal medicine specialist. They do bedside shift reports together. And as Bill mentioned, all the team, the OB nurse, the ICU nurse, the intensivist, the maternal fetal medicine, and any subspecialists or other disciplines, we gather, at least before COVID, we gather outside the patient's room every morning and discuss everything about the patient and about what needs to be done and what things to watch for. And that collaboration is just invaluable to providing the comprehensive care that these patients need. If the patient has already delivered, there may or may not be an OB nurse in the room, but there is an OB nurse assigned that the ICU nurse can call for any kind of questions. That support continues even if there isn't a passenger on board.
And I would also, I would also highlight that one of the things that is the most difficult part of this, where our nurses, our spiritual care, our social work, we always need to remember, particularly those moms who have a baby that is within the same geography, but not necessarily immediately next door. This is a major particular issue. Mom wants to be with her baby, and her baby wants to be with her mom. And sometimes within critical illness, that may not necessarily always be possible. So we've taken, again, great pains. We actually have a network of which mom and their family, if they are under our oversight within one of our critical care areas, throughout Abbott Northwestern, we actually have what's known as Baby Link, where in fact they can see their baby, whether it is in newborn nursery, special care nursery, or a higher level of care that is in the neonatal intensive care. So again, that's one thing that is slightly different, if you will, than other critical care programs, that even in the mom who has had a successful delivery, she's still somewhat separated, if you will, from that 39 to 40 week long marathon. And we have attempted, and I think done a very good job in the ability technologically to be able to provide that bonding, even though it's not as much bonding as might necessarily be needed through those first, if you will, few days following delivery. So that's really been an important part of our program.
Yeah, yeah. Even more in the time of COVID.
Yes.
Although whenever possible, we do allow babies to come over and visit, and they bring over a bassinet or whatever, and the babies are in the room, and moms can nurse them if it's possible. So it's kind of fun to hear a baby crying in the ICU and to go in and visit too. So moving on. So I just show this because this partnership is unique. We have publish this and in nursing literature, and we hope to publish it in medical literature for too long. This is the scope of the program. So there's the OB Critical Care Program at the center of it, but it interacts with all these other programs that are present that Dr. Wagner's involved in pretty intensely. Maternal acquired heart disease, so we have our cardiologists and CV surgeons, high-risk pregnancies, maternal acute illness, just the general acute critical care illness, maternal congenital heart disease that Dr. Wagner mentioned, and then the morbidly adherent placenta, which is also what he mentioned when he was talking about the accreta. All those areas are within the scope of this program. So, and here's a slide looking at our outcomes so far. We started in 2018. So where the column that says target, I couldn't scratch out target and put 2018, but in 2018, we had 86 patients. 2019, we had 96 patients. And then in the first 2 quarters of 2020, we had however many this is, whatever that is, 31. So total, we've had 213 patients go through this program so far. These are patients who have come to the ICU for one reason or another. Their average age is about 31. We do have some that are over 40. We have a variety of ethnicities, but not really as much as we want. And we need to work on our outreach for the minority. to get them involved in this program. And you can see our diagnoses are many of the things that we've talked about, the hypertensive conditions, sepsis, hemorrhage, cardiovascular problems, blood clots. So these are not your run-of-the-mill average healthy patient who winds up in the ICU for a night of observation. These are people who are very, very sick and who have the things that are related to maternal mortality. And yet, as Dr. Wagner mentioned, of those 213 patients, we haven't lost one yet, knock on wood. So we're very proud of this program. We think it makes a big, big difference. And we're hoping to spread this kind of model throughout the country. There are not many centers that can do this, but there are some who can, and we're hoping to spread it with talks like this and talks at medical institutions. And also, one of the things that we wanted to track, because it's very important, is the infant data as well. Just because they're not 213 live births, that doesn't mean that we lost patients. It means that not every patient delivered while they were in the ICU. They may have delivered before, or they were in the ICU and left and then delivered later. So that's why that's the case. But we're finding that while a lot of patients, their moms are sick, the babies may be struggling a bit, they may wind up in the NICU, but their mortality rate is also low. And for that we are grateful, and we'll be tracking that more. So, and then this is how anybody can get in touch with either me or Bill or a OB ICU resource person that we have on call 24/7 through these numbers, if you have any questions or anything. Bill, let me give that to you for any comments.
Yeah, you know, I think that part of, you know, the key, I think, to these discussions is, you know, again, to summarize, not necessarily to highlight the program, but I think that it is important to highlight the amount of work that everybody has done. And obviously, Lisa knows that I will be forever grateful, having been given the privilege to be Lisa's partner on this program. I'm actually, as some people refer, you know, with the new flu vaccine, I'm one of the old guys who has to get, you know, the big boy vaccine as opposed to the regular vaccine. But I say that, if you will, anecdotally, that this has been a privilege for all of us to be a part of this program, to provide the level of care that these patients clearly deserve. But you can clearly see we have a lot of work to do. And I think, again, the concept of not only these forums, I think, that are informational and helpful, I think they also highlight, if you will, the needs that we do need to somehow move to greater access, improve, if you will, the health and welfare of moms who are considering, you know, this marathon called pregnancy. And I think, again, as we move this program forward, I think necessarily it will be a benefit to the moms and the babies of the future. But I do want to highlight that we will continue, hopefully, you know, to provide for the needs, and hopefully provide for the needs prior to the time that the patient necessarily would require Lisa and our expertise.
I mentioned that we would mention COVID, that the data, you know, it's a new disease. We're finding how it affects everyone. It's all new to us. In general, and correct me if I'm wrong, Bill, that pregnant women wind up hospitalized for COVID more often. And I don't know if that's necessarily out of abundance of caution, or if they are a little sicker than the average young person who develops COVID. But their outcomes are better. Their survival is better on average, even if they wind up in the ICU. And and again, it may be because they're healthier and younger. We have had patients, I've taken care of patients who are pregnant, who've come in with COVID, who've had to be intubated and put on ventilators during their pregnancy. Most of the time, if that occurs, if the patient is at a delivery age, excuse me, if the fetus is at a delivery age, we go ahead and deliver the baby because that takes a lot of stress off the mother. There also are times when mothers have to go on extracorporeal life support even while they're still pregnant because their lungs or their heart fail, but they tend to have better outcomes. And so COVID and pregnancy, it's a fascinating area, and we're continuing to study it. Hopefully our outcomes will continue to be as good as they are.
Yeah, and they have been. You know, one of the things that, because this particular condition seems to have a number of, let's say it's multifactorial. What we thought we knew in February, in fact, may be changing as we are looking now in October into November of 2020, particularly as it relates, if you will, to this illness and pregnancy. The initial assessment was that it probably had limited impact on relatively healthy moms who were pregnant. Certainly did not appear to have any particular impact on their developing babies at almost any of, if you will, the weeks of pregnancy, whether they were early on in pregnancy, kind of through the mid part of the pregnancy or the last part of the pregnancy. And they seem to, again, appear to weather their particular illness, which, as many of you know, may in fact impact more than just the breathing issues. It affects their kidneys, it affects their heart, it affects almost any particular organ that the virus may become in contact with, although certainly the lung issue has been the most prominent. We are now beginning to see a bit of a change where depending again upon certain factors, again, body mass index probably being one, some of the other health conditions certainly that everybody's worried about, particularly in individuals of my age at 68 years young with some other chronic illnesses, even in pregnancy, may, if you will, have a more, if you will, significant need for supportive therapy and in hospital care than they did before. And the one thing that clearly has really come about really in the last 3 months is that although their illness appears certainly, shall we say, to be treatable and amenable to most of the modalities we're using, the length of time that they have continued lingering symptoms in pregnancy is much longer than if you're not pregnant. That is one thing we are now beginning to see, that the mom who is pregnant who gets COVID, even if they do actually very well, they have many of these lingering symptoms for a much longer period of time than non-pregnant individuals. So again, we're learning something new about this particular condition every day. The biggest concern, obviously, now is the new recent surge, but if you will, because of a number of factors. We certainly are well aware of the, shall we say, pandemic and viral fatigue, and now many of these particular cases are not coming from large gatherings. They're coming from birthday parties where there's only 5 or 6 people, but if you will. So the other concern we obviously have, as we are with any potential infection, is how rapidly, if you will, the genetics of that particular, organism may be, where they may begin to change their own genetics, where what we thought, if you will, we had a handle on vaccines and these kinds of things, antidotes and antibodies. If in fact a virus changes its genetics, it won't be as amenable to treatment as it was. So I think, unfortunately, all of us clearly suggest that we are going to be in this for some time. And even despite the concept, if you will, of a vaccine, which may or may not necessarily be more globally available until early 2021, many of the current mechanisms and measures we are trying to reduce, if you will, its transition may in fact need to continue for a longer period of time than any of us would like, which obviously has tremendous social and economic, if you will, consequences to almost everybody. We could use a little help from upstairs. That would help us. That's how I'll end this. We could use a little help.
Yeah. So we have some time for questions. I know we've given you a lot of information and not a whole lot of time, but I'm happy to entertain any questions. Let me see if I can find my way into the chat room and see if there are any chats, which I don't see.
I don't know if you can hear me.
Yes.
I have a question. When you raise the economics, we've been big time concerned about cost, and I don't know how to exactly ask the question, but will the cost factor be limited or affecting accessibility to the program that you hope to spread across the United States?
Go ahead, Bill.
I would say to the stress within all of the health systems that they have had to endure over just within our particular state and within our region, the stress of this particular condition, COVID, has had almost the same impact as it has in the other areas of the economy, like, if you will, the hospitality industry, the travel industry, all of, every industry has been obviously very adversely affected, some more than others. But I think both Lisa and I would agree, even with the esteemed institutions that we are associated with, Alina, even the esteemed institutions that you all are associated with in your geographic area, Mayo Clinic and many of the others, very difficult, if you will, priority decisions necessarily are going to need to be made to try and direct the healthcare dollars where it is needed the most. Where that will be, and I believe, is it Ted? Yes, I just wanted to see where that will be, Ted. I can't say, but your question is absolutely apropos, and we're a long ways away, even though we are a bit unstable, underfitting in the ground right now. Every, if you will, hospital organization is still, if you will, backpedaling to decide where are we going to put the resources which will benefit the most people, recognizing that there are significant resource limitations, if you will, and as I usually describe, that, the limitations of either any particular program, whether it's healthcare or whatever industry it is, it's the three-legged stool. It's resources, time, and money. And all three of those particular legs of that stool are in relatively short supply at this point in time. And I think both Lisa and I will underscore, we're holding our own right now. If we, again, begin to see, as many of the potential hospitals in our even 5 surrounding states and otherwise, if we begin to surge again, we will be in the same, not only resource, if you will, limitations, but in issues related to where are the healthcare dollars coming from and where are they going to go?
Yeah, that's a very difficult question, because obviously, every provider wants the dollars to go to their area. We have, in our institution, we've made it a priority, and we've gotten Alina to agree that pregnant patients or patients within 6 weeks of pregnancy are a priority patient, so that if we will never turn one away, even if we're full, we will manage to find a place for them at our institution if they need to come to us. Fortunately, Alina has agreed to that. The surge is coming. We're seeing it coming. Our resources are limited, particularly nurses. Oh gosh, if any of you all are nurses or retired nurses, please get your licenses and come back to work.
Yes.
Because nurses are gold right now. But all we can do is try to prove. I think one of the things that helps is that we can prove that our program makes a huge difference and has good outcomes. And I think that kind of data will help as far as with patients in our program. Other areas, it's very difficult. And I've been involved, and Bill has too, in these even statewide discussions about scarce resources, limiting resources, withdrawing care on patients. It's not pleasant. And I hope we don't get there in Minnesota, but we know it's happened in other areas. So that's all we can say.
My concern is also, it's even bigger than COVID, because all of us know right now, the Affordable Care Act is before the Supreme Court. And then, at least that did provide some cost support for, healthcare. And if it's shot down, I just can't imagine what that's even doing to any experimentation and research that's going on.
Right. Agreed?
Yep, I would agree. But I think all of us, within the camp of, shall we say, logic and integrity, can look at many of the pieces of that particular program, no matter what its shall we say, namesake is necessarily. But the concept of care to those who need it, who clearly, if you will, have conditions that pre-exist whatever particular issue they're in, clearly needs to be maintained. And one of the things I will say is that I think that the concept of, as it is with anything, the support, if you will, for programs, particularly within institutions, really needs to be augmented by, if you will, ordinary individuals who do see the benefit of the program, and philanthropic issues, if you will, are a part of the major piece of almost all healthcare organizations, as Lisa and I know, the Alina Foundation and Mayo Foundation and many of these others. And if you don't think that Lisa and I haven't thumped the sidewalks, if you will, as I've always said, one of the most difficult things in the world is to ask somebody for money. But the fact of the matter is that almost every organization, even those with relatively sizable endowments, are stressed at this point. And actually, many of the things that we have looked at in terms of improving our program, again, which includes access and many of the other particular pieces of this jigsaw puzzle, which we think will benefit patient care, we in fact have needed to go, if you will, outside the organization and move, if you will, to philanthropy. So it's a huge issue. That's why, I think these forums, I think, are so important to give people an idea about what we do, how we do it, what are our outcomes, what benefits can we provide to the global network, not just a narrow group of individuals, but an entire global network of people who obviously require this level.
I have a question. Following up with what Joel posted, and then I have a second comment. How far do your patients travel to come to your center? How far out are you able to reach to get them to come in for care at your specialty center?
It depends, Maybelle, on what their underlying particular issue is. for, let's say, a mom who may necessarily require the care of our placental program, as we talked about, our adherent placenta program or our accreta program. In fact, we are the regional and 5-state center of excellence for the management of those patients for their particular pregnancy care, their delivery, and their post-delivery care, because it takes a tremendous amount of surgical expertise and multidisciplinary care to manage these patients. We may get them, if you will, from Montana, Nebraska, North Dakota, South Dakota, Iowa, Wisconsin, because that unique profile of patients, the resources that it really takes to manage those, as well as, again, remember, the more you do, the better you are, and certainly those that are high volume centers have much greater outcomes. Certainly Mayo is the, shall we say, you know, the gold standard for this, but certainly within that profile, Mabel, I will tell you that they come from as far away as 5 states. Many of our particular congenital heart patients, if you will, who have had previous palliative and surgical correction of their congenital heart disease, many of them now do come from North Dakota, South Dakota, Iowa, Wisconsin, as well as both metro, if you will, regional, and outstate of Minnesota. So it is a very, if you will, well-known program, again, putting all those disciplines together.
Okay, my second question, I don't want to butt in on people. I moved here from the Upper Peninsula, Michigan. Marquette was pretty much the hub for high-risk care there. You have more, I'm a retired nurse, pediatric maternal child was my area, but more family practice physicians are choosing not to do deliveries. And so these women then need to come into the local area. For many of them, it's a 2 to 3 to even more hour drive, which when you have 150 inches of snow in the winter, I think some of the things that I've seen happen in our area was using public health, home health nurses with an expertise in high-risk pregnancies. But I'm also thinking with the technology that we've developed with COVID, I wonder if that can't be another possibility for monitoring some of these women, because it's not feasible for them to, you know, come in real often for the specific checks that I'm sure are done. So just throwing that out. And then one third thing is, I'm wondering in the UP, just like in Minnesota, we definitely have a Native American population, and you know, what are ways to reach out to Indian Health Service or whatever they're using for their care, because obviously statistically, those are underserved women. So those are my comments and feedback, and I've really enjoyed your presentation. Thank you.
You're welcome. And Mabel, one thing, and I think Lisa and I would both underscore, the new concept, if you will, if COVID has done nothing else, it has pushed the concept of telemedicine and telehealth, if you will, to the forefront. Many of us within this local region were probably anywhere from 3 to 5 years behind in terms of telehealth. That is giving people the opportunity to stay within their geographic region and get, if you will, oversight and care as if Lisa and I were actually looking at them. And actually, one of the highlights, and probably not enough time for Lisa to give you the highlights, they have now developed really a great telehealth, if you will, ICU forum, to where, in fact, they can keep patients in step-down units, or they can see the patient visually, if you will, with the provider. And again, it's not to minimize those patients who require quaternary care, but recognize that there are many patients, and if you will, critical illness notwithstanding, even in the concept, if you will, of prenatal care and perinatal care, in fact, that is a major emphasis, if you will, of all of us, if you will, and particularly through Minnesota perinatal physicians, as well as, if you will, the tele-ICU, that many of those patients that you described, Mabel, that is how we can best serve them without them driving to Duluth, if you will, from the Upper Peninsula or other issues. So as I say, COVID hasn't done us any favors, but if anything, it has really pushed, I think, not only us, but the nation in terms of telehealth.
Right. Yep. Yeah, we're finding that we, being my my critical care partners and I, that we can call and even have telephone rounds with providers in other hospitals, even if they don't have a ICU setup where you can see their patients. We can talk things over with them and give them advice or recommend when a patient's ready to transfer. So it's funny because we've been, I and my partners and I have been trying to get tele-ICU going for 16 years.
Just about.
and in 7 months, it's going. So I agree. That's something that's come out of COVID. Any other questions?
I'd like to, I asked this on the chat thing and I did get an answer from you, but I think it's very important for us to connect as citizens. The statistics you gave at the beginning of the difference in mortality rates from our country and others who are probably developed country, are all developed countries as we call it. You know, growing up and for years now, we've just had the idea that we're very forward and advanced country in terms of mortality. And when you see these statistics, it's a real moment for pause to say, now, what has happened or what isn't happening that would get us who are in the most affluent country in the world in this situation. And I can't help but think, certainly the COVID epidemic has brought this home more and more, is that we have such a weak public health system in our country, that the prenatal care that is available in many of these countries without charge and to the whole citizenry, not just the ones who can afford it, it could make a huge difference in the numbers. And I just wonder if you feel that concern that we are not even educating people of what a robust public health system looks like.
I could not agree more, Eileen. And I think if you look at years back, I think there was a much greater emphasis on, if you will, the public health system than there is now. And again, I don't think necessarily it's just because there is a shortage of healthcare dollars. I think it really runs the spectrum. It's very difficult, you know, to get individuals, you know, to take a year or two, let's say, of public service within the public health system, which used to be a fairly common phenomena, Eileen, as you may remember back in the 60s and 70s. Many physicians, if you will, did take a year or two within the public health system. Many of them, if you will, were stationed in New Mexico and Arizona, particularly with the Navajo Nation, many of them up in Rosebud, if you will. And there was necessarily an interest in that. Probably, I will tell you, Eileen, the biggest drawback to, if you will, that particular interest in the public health system is the, if you will, individual cost of most, shall we say, medical students coming out of medical school who the average, if you will, debt and payback now, and I'm not just talking about the Ivy League institutions, I'm talking about the average. The average current medical school debt of all medical students now graduating is just slightly south of $300,000. So you can imagine that you have individuals who are staring at $300,000 in debt, and they look at, well, you know, I'll never get it paid back if I go to Rosso. I'll never get it paid back if I do something, if you will, for a couple of years, as they begin to say, well, you know, doctor, you do need to start, if you will, paying this back. And again, it's had a tremendous impact on, clearly an impact of those who will go into primary care. It's had a tremendous impact on those who are looking, if you will, at subspecialty, not because necessarily their interest or their goal, if you will, was to do one particular discipline in medicine. They look at, in fact, what can I do of which I can get out of it underneath this debt if you will, so that I might be able to buy a house, raise a family, and have just, if you will, even if people would describe as a middle class, but shall we say life, because there are still, you probably can't believe, there are still people in their 60s that are still paying off their medical school debt. I can tell you, I can remember when I wrote the last check, but it is a major issue. And I think this is where, NYU at Langone, as you know, now has a program where all those kids necessarily, if you will go through medical school, and when they graduate, to move on to whatever their respected internship or residency or discipline is, they are debt-free. And that has a tremendous impact. Now, where is that money coming from? It's coming from philanthropy. It's coming from the Langone family, who decided that that's where the endowment was going to be put, because they could clearly see that those individuals coming out of medical school, whom in fact are actually paying their own way, which is probably about 2/3 of individuals. The other third obviously may come from an economic benefit that doesn't require them, if you will, to get outside resources to help them pay. But that is the number one issue, if you will, facing medical students today, is an insurmountable amount of debt when they come out, notwithstanding some of them may have $50,000 to $100,000 worth of college debt. So there are people who are actually coming out of, if you will, medical school with somewhere in the neighborhood of $500,000 or $600,000 in debt. And all of us recognize, you know what, you never get that paid back. There are people whom I remember when I graduated from medical school from the University of Iowa in 1985, who had tremendous amounts of debt. And even in the, shall we say, mid to late 90s or early 2000s, there were several of my friends in family medicine and in pediatrics, because of their debt service, they declared bankruptcy. They had to close their practice and do something else. So, Eileen, it's a major issue. It expands farther than the public health system, but that particular piece of access of care, I think, is almost virtually zero now.
So I have a question. What is the national policy on public health?
What do you mean? Can you elaborate a little bit on that?
Well, I'm just wondering, do we as a nation have a public health policy?
I think we do, but I think over the last few years, I think it has been put on the back burner. Again, any particular public policy, and trust me, I'm not a very good resource on this, but I think any particular public policy which necessarily is overseen by, shall we say, all three branches, if you will, of the government, who is obviously making decisions surrounding that. It's not an endowment. It is funded, shall we say, by each of those three branches, I hate to say. And the current, if you will, public discourse that we have, shall we say, and the inability really to accomplish almost anything has, I think, had a tremendous negative and to some degree terminal, if you will, issue related to our public health service. And I will say on one of the chats, the one thing, again, I would 100% agree with, particularly from the standpoint of obstetrics. The midwifery program is an absolute essential part of, if you will, prenatal care and delivery, and is, and particularly a major emphasis at Allina to expand that. And many of the patients now are very well served, if you will, by our midwifery programs. I think, again, as it relates to the public health service, and particularly if it is the need for some agreement within public policy, I think we need to figure out how we can agree on public policy, which hasn't occurred.
Yeah.
So
most public health, as Warren was reminding me, is really left to the states, and it's up to the states. But one thing, if there, again, any good things that come out of COVID, and I'm probably optimistic here, is that perhaps starting with the distribution of the vaccine, that perhaps a restructuring of public health may start, you know, that we have data on who does worse with when they get a COVID vaccine, so that those people should get, I mean, when they have COVID, so that those people should get the vaccine first. And I don't know, I'm hoping that maybe that could be a ground level restructuring, but I'm not optimistic.
And one of the things that I think
that it's,
yeah, go ahead, Eileen.
I was just going to say, I think it's so important as lay people that we are able to narrate with others that we have been programmed to think that private care is excellent and anything else is not. And so we look at public health in a way that, well, it's less than if I could go to my own doctor. And I think we've just got to do something nationwide to educate people that care can be excellent, as we see in some of the other, especially Scandinavian countries, which it doesn't take care of crisis care, but it takes care of the day by day issues that people face in their health. And we've just got to do a huge education program on this, because the pharmaceutical and the insurance companies do not want us to take that position.
Well, and Eileen, I think you bring up a good point. And again, I think it underscores, as Lisa and I suggested when we started the program, despite the fact that we wanted to create a program to help those who were clearly in need of it, the most important piece was educating people how to keep people out of our unit. And I think exactly what you bring forward. One of the things that American healthcare having, or shall we say North American healthcare, although I think Canada has been certainly on the forefront much more than we have. You're right. Where we have made the greatest strides is in acute crisis care and damage control. And yes, our outcomes within trauma, our outcomes within high-risk cardiovascular disease, our outcomes in terms of oncology, all of the particular disciplines, we've made great strides in addressing a problem that exists. The issue is that we've done a very poor job in keeping people out of those issues. That, you know, they don't exercise, they smoke, they overeat, they're obese. They're doing all the particular issues of which crisis care actually, which is very expensive, can help them much more than it could 50 years ago. The problem is we have people whom have gotten used to the fact, well, you know, if I get sick, I'm living in the greatest country in the world, and they'll cure whatever ails me. But I think you are absolutely right. Educating the public, if you will, surrounding the concept of that to be an advocate for your healthcare, to be an advocate for, if you will, access, and to be an advocate, if you will, for what is the most important. Again, you know, with those resources available, I think you know, is going to be the most important. Backpedaling is we're very good at, but we have not done a very good job in the last probably 50 years in terms of you know, putting people in the forefront in trying to stay out, if you will, of the need for healthcare by adopting other avenues for them to access healthcare before the crisis occurs. That's where we have really, I think, when we look at our statistics, you could just look at them as to how healthcare is delivered in this country.
I have a question and a comment, or maybe the other way around. And that is, the comment is in regards to the last comment, the statements is that, well, that's our quote, freedom as individuals, which is part of our struggle, is that we see so much individualistically. But the other question I have is, will this particular discussion and your presentation be on a video that I can share with our, I'm part of the Planned Parenthood committee here in town, and like to have that available, because I think it's really an excellent, at least to open up some other conversations with Planned Parenthood people.
Yeah, Gary, this has been recorded, and
good.
so it'll be available.
Yeah, I think it will be.
At least,
yeah.
You know what? I'm sorry. I should say up to an hour of it was recorded. Actually, I think the discussion since about 11 o'clock probably has not been recorded.
Well, it's okay. It's a good start. Thank you.
Mm-hmm.
And Oliver would be the person to contact on that.
Oh, okay, great.
Well, is it time to wrap up, Lisa?
I guess so. I mean, I'm enjoying this. I think we could talk all day.
Yeah.
And Lisa, just as an aside, thank your next door neighbor Warren there for keeping us honest here. Thank you, Warren.
he's laughing. Yep. Yeah.
Well,
so thank you all.
Yes, thank you so much.
Thank you.
Well, thank you.
Well, we want you to know that this is the kind of thing we really want on our forums, something that makes us go into new territory that we don't think about very much until we have a relative or a friend who is caught in a situation where they need this kind of care. And I really am a believer in presenting things like this to people so that they can narrate to others that there is this kind of program available. And I want to thank both of you for taking the time to do this. This is not a big opportunity in terms of numbers, but it is a concerned community. And we're very, very thankful for your time and effort and all you do daily to help persons in need in this area of maternal health and neonatal care and all the rest of it. So thank you so much.
It was a privilege, Eileen. And Lisa, again, I thank you for the privilege for being asked to be a part of this. Thank you, everybody.
Thank you, everybody. And if anybody wants our slides, you're welcome. Just let me know.
Absolutely.
Thank you very much.
Thank you all.
Have a good week, everyone.
You too.
You too. Now I got to figure out how to end this.
Click leave.
Yeah, I have to do a little more than that, but let's see. End. Okay.